This is Dr. Akinepalli, Interventional Fellow at Creighton University Medical Center. I'm going to briefly review about the femoral artery hemostasis in cardiac catheterization laboratory. So, few slides about anatomy of the femoral vessels. Abdominal aorta divides into bilateral external common iliac arteries, and common iliac artery divides into external iliac artery and internal iliac artery. So, this is common iliac artery divides into internal iliac and external iliac arteries, and external iliac artery continues superficially to become common femoral artery. Common femoral artery divides into profunda femoris artery and superficial femoral artery. The next slide show you the relative anatomical relations of the vessels. So the external iliac artery that you can see is a retroperitoneal structure, meaning close to the spine behind the intestines, and it dives superficially and crosses the inguinal ligament to become common femoral artery, and which divides into profunda femoris and superficial femoral artery. So the segment that we want to access is this segment right here, common femoral artery. That there are few unique things about the common femoral artery. This segment doesn't have any branches, and this is immediately on the top of femoral head. So it is easy to compress and achieve hemostasis. And when we mean high stake, accessing the external iliac artery, as you can see, it gives number of branches, and there is a good chance to enter through one of these branches to cause continuous bleeding, or if the access site where we enter the external iliac artery has a bleeding complication, it can bleed into the retroperitoneal space and cause significant amount of blood loss, can be fatal. So when patients have high stake and external iliac artery access, the bleeding from this artery could be invisible from outside because it's all inside in the retroperitoneal area. And the low stick means sticking below the bifurcation. And these are slightly deeper structures, and there is no bone behind these vessels to compress. And also smaller arterial size make uh, occlusion and other complications, chances of other complications more. So the ideal site to puncture the artery is in this segment of common femoral artery. This is another representation of showing the arteries: common iliac, internal iliac, external iliac, and as it crosses the inguinal ligament called common femoral artery, and superficial femoral artery and profunda femoris artery. So when we do the access, we mark under fluoroscopy about mid-femoral head, and we start the skin entry point about 2 finger breadth below and aim to enter the artery at the junction of upper 1/3 to lower 2/3 of femoral head to access the common femoral artery. That you can see here, the sheath enters the artery about here. So the skin entry point is always lower than the actual entry point of the artery. So if you're holding at the skin side or below the skin side, you might not be compressing the artery. So you always hold about 2 finger breadths above the skin side to actually compress the artery and achieve hemostasis. So this diagram represents the proper technique to hold pressure. So if the patient has a sheath, you have to identify the pulse proximal to the sheath as shown in this picture, and once you identify the pulse, you have to apply very firm pressure, occlusive pressure, and take the sheath out. The occlusive pressure should be about 3 to 5 minutes, followed by the moderate pressure to just enough to prevent bleeding. And if you want to support your hand with the other hand, you can do so to avoid fatigue. So the time of holding pressure is approximately twice the size of the sheet. For example, 5 French sheet, you have to hold pressure for about 10 minutes. In 6 French sheet, you have to hold pressure about 12 minutes and so on. And another common misconception is closure devices are associated with less complications, but that's not actually true. All closure devices have very similar bleeding complications compared to manual pressure. So having a closure device does not necessarily prevent from having a bleeding complications after the cardiac catheterization. You can see in this table the top two. So if you compare across the all closure devices, the bleeding is very similar. And one important thing is to remember when you're taking care of heart post cardiac catheterization patients about retroperitoneal hematoma. As I said earlier, retroperitoneal hematoma can be is associated with a high stick, meaning sticking above the inguinal ligament in the external iliac artery, and patient can have no hematoma outside visible. So it's very important to have high index of suspicion. Patients with hypotension associated with back pain are the classic symptoms of retroperitoneal hematoma. So if patient has high stick to begin with, and if they have back pain and also have hypotension, so they should be screened and treated for retroperitoneal hematoma. The first line of therapy is fluid resuscitation, followed by the diagnostic test of CT scan. CT scan can be performed without contrast initially to rule out retroperitoneal hematoma. Contrast study can be performed to see the extent of bleeding and if there is a continuous bleeding. Patients might need to be transfused blood if their hemoglobin drops significantly. So the other two diagnoses are associated with hypotension in post heart cath patients are one is cardiac tamponade and postoperative MI, which can be diagnosed with EKG and echocardiogram respectively. So as discussed earlier, retroperitoneal hematoma is not compressible because it's higher up in the retroperitoneal space. So these patients needs to be aggressively resuscitated with fluids and blood as needed. And if there is a continuous ooze, patients needs to be treated either endovascular or surgical intervention. Endovascular therapy can be a balloon tamponading the bleeding artery, or sometimes needs to have coil embolization if the smaller branches are involved. Some patients need surgical intervention to stop the bleeding. So this is a brief a summary of femoral hemostasis and identifying the retroperitoneal hematoma after cardiac catheterization. The proper technique, the take-home messages are identify the retroperitoneal hematoma in patient with hypertension and back pain, especially if there is high stick, and learn proper way to hold pressure to achieve hemostasis as shown in this picture. Diffuse pressure with the palm or fist is unlikely gonna help or unlikely uh, help to achieve good hemostasis. The good hemostasis should always feel the pulse and able to apply pressure directly on the top of the artery, should be just above the skin entry site to compress actual entry point to the artery. I hope this helps. Thank you very much.